before, but it's because some of these slides here in the middle you can kind of read through. So let's move to the medication slide. It has the word antipsychotic. And we'll come back to these other ones, but if we didn't get to talk about those, you guys can kind of read through them and tell what is meant to be said there. Okay, so antipsychotics. We have first, second, and third generation. First generation is the traditional type. Okay, talk about. Shh. You can't mute you guys in person. Second generation is atypical, and third is what we call atypical. So my rule on medications throughout my lectures is pretty much know the general characteristics of the class, and then study, the main medicine or prototype for that class, and know what else goes in that class. I'm not expecting you to memorize every single medication, every single side effect for every medicine. But generally speaking, if you understand the way a certain class of medicines works, then you're going to pretty much be able to answer questions about those. So, first generation. Oops, I skipped one there. First generation are the traditional antipsychotics. These meds are older, so they have a lower price point. I did. Yes, but it's always good to check. They also have a higher risk for adverse effects. Since this is a lifetime diagnosis, lifetime expense, that price point can be a major issue when you think about over a person's lifetime. So they're going to try them on a traditional first, because if that will work for them at a low price, it's going to make adherence easier for them. Chlorpromazine is the prototype for this class, so that's the one I want you to focus your studying on. There are a lot of broad rules that we'll discuss in a little bit about these meds, and things that apply to this one specifically. Since it's first generation, has that low price point, but more side effects, has a black box warning for increased mortality in older clients with dementia. So you would be especially watching those clients when you start them on this medicine. As with most meds that we will talk about in mental health, not all, but most, usually takes a few weeks for these to be effective. You need to teach your clients that.
Mrs. Hayes?
Yes.
Deborah asked you, did you say what was the question?
Well, no, what was the medication that she said was
the question?
It's that first one on the list.
So
Yeah, chlorpromazine, yes.
And what did you say about the elderly?
Increased mortality rate in older clients with dementia.
You got,
Yes,
you got
yeah.
faster than they could ride.
Okay, sounds good. It's also, I believe most of this came from your drug book. So if you're missing stuff, you can also look it up there. But it came from, it's a black box warning for increased mortality in older adults with dementia. And then we were kind of overall just talking about the fact that with a lot of mental health meds, it's going to take weeks for them to have effectiveness, and your clients need to know that, otherwise they're going to take it a few times and go, I don't feel any better, and then stop taking it and not really give it time to be effective. This one specifically may take as much as 7 to 8 weeks. So that's a long time of taking a med, right, before they feel better, so they need to know to expect that. True also of most psych meds, you do not stop them abruptly. You need to taper off of them for a few weeks. And that's true of this one too. Specific to this medication is you need to make slow position changes, so it can cause lower blood pressure and orthostatic hypotension. This one may discolor their urine. It may be pink or reddish brown, which once again, if you think about people who are having these paranoid thought processes, that's going to really stress them out if they aren't prepared for that. So be sure you're teaching them that. Yes, pink or reddish brown. This medication especially causes sun sensitivity, and that's true of some of the other antipsychotics too, but they need to have UV protection, so long sleeves, hats, sunscreen, even sunglasses to protect their eyes from UV damage. They can commonly get candidiasis, which is a fungal infection in their mouth. So oral hygiene is really important. Remember, once you deal with the population, where until the medicine starts to work, they're not really going to be motivated to do those hygiene things. So be sure that you discuss with them why it's important. That's more than just a basic hygiene thing for them right now to prevent that infection. They're going to need to use caution in driving or high-level mental activities until they kind of know how they react to this medicine. Just this class. Yeah, we're still on the first medicine, but this is the one you have to study for first generation. And then also this medication can commonly cause vision issues that need to be reported. So if they're having eye pain or anything like that, they definitely need to tell you. I think there's a slide that will address this, but medication adherence is always a major issue typically in psychiatric nursing. The better you can prepare people for the side effects, the more you can get them to tell you, because sometimes if they're having a side effect, they'll just stop the med, right? And then they're not getting treated at all. But if you can get them to, kind of know, these are the side effects that are temporary and usually go away. These are the side effects I want you to report to me. Because a lot of times you could switch into something else and they would be able to continue taking the medicine. So be sure you're kind of communicating with them the importance of reporting. If, before they stop taking it, if they're having a side effect that's making them want to stop taking it, have them come talk to you so that you guys can try something else on. Second generation, the next slide. These are atypicals. The prototype for this group is clozapine. It's that first one that you see there on the older list. Overall, these meds are going to work differently and have a better effect on negative symptoms, but being newer, they're going to cost more. They also are going to cause some metabolic dysregulation, so they're going to contribute to like the metabolic syndrome, obesity, and all those comorbid conditions that go along with obesity, hypertension, diabetes, cardiovascular diseases. Yeah, they're going to increase the difficulty in keeping from gaining weight, basically. The big thing to remember with this particular medicine is it has a black box warning for what can be potentially fatal agranulocytosis. I'm going to spell that for you since it's not actually on the slide. So AGranulocytosis. So granulocytes are our white blood cells, right, that fight infection. So if we have agranulocytosis, that means we're going to have a severe reduction in our white blood cell production. That's what we're looking for in these people. Typically, we're only going to use, for this reason, because this is a potentially fatal side effect, we're usually going to try these people in the first generation ones first. And then if they don't work, we would move them over to this. We need to be very careful in our management of this treatment. So they're going to need a baseline weight, a CMP, comprehensive metabolic profile. It's a lab test. A fasting glucose, fasting lipids, and a CBC. They need to have a neutrophil count that is over 1,500 for us to start them on therapy at all. And we're going to recheck those neutrophils every week for the first 6 months of therapy. Yes. You need to educate them on why that is an important lab test. Every week for 6 months. And explain to them why, because they may just think, well, this is routine lab, it's not that important. So they need to understand what you're looking for and why you want them to do that. In addition to that, we'll talk more about more lab, but they also need to report any signs of infection. Because it may tell us that they're even between lab tests that something's going on. So once you get through the first 6 months where you're checking weekly, you're going to check every 2 weeks for 6 months. Then every month for the rest of therapy. Because of the metabolic issues, we're going to recheck their glucose regularly too if they're not diabetic. And we're going to monitor them really carefully if they are diabetic before they start it, because it's going to affect their glucose too. When they stop it, we still want to monitor. We want to go back to weekly draws for a month after they stop the medicine to watch their neutrophils as they come back off of it. third generation. These kind of are a lot of different ones. We're going to talk about the first one. It's not necessarily the prototype because this is a relatively new class, but aripiprazole, I'm not very good with that one. As you'll see, it does a better job of restoring homeostatic balance. So basically what that means is it does a better job of mimicking what the body would normally do on its own for us. It does have a favorable side effect profile, but if it's newer, and this is commonly called Abilify, and you see ads on TV, what is it probably also? If they can afford to advertise it on TV, are they making a lot of money off of it still? Probably so, yeah. So it's still under patent, and so it's probably going to be expensive typically with the newer ones. Let me see if there's anything else. You do have a black box warning on this one for increased suicide risk in elderly, adolescents, and children. It has a better side effect profile, but you still have the weight-related issues with metabolic regulation, so you still need to check glucose. They may still have some orthostatic hypotension, so they need to be taught slow position changes while they're adjusting to it. And because of that black box warning, you need to be super alert to signs that they might intend to harm themselves. What do these meds do for us overall? They give us emotional quieting and sedation. So this is both a therapeutic effect and a side effect. It'll help with their insomnia, make them more sedated, decrease their altered perceptions, kind of just give them some calm and quiet. At the same time, it may increase those other symptoms like lack of energy and things like that because we're kind of chilling them down. And so it's going to make some of those negative symptoms worse. Get some psychomotor slowing. So less of those agitated, continuous motions. We talked about it's most effective on positive symptoms. So we're going to see the greatest improvements in things like delusions, hallucinations, psychomotor agitation, the bizarre behaviors, the hostility, suspiciousness, those things on that positive list, that's where we're going to see the greatest amount of improvement. You're going to have less direct improvement on the negative symptoms, although sometimes getting rid of the positive symptoms is going to help us with some of those negative symptoms because if they have less of those bizarre behaviors, then their social withdrawal may improve. If they're less suspicious, then they're going to be able to interact with people better and do better at work and things like that. So you get some effect on the negative symptoms, but not necessarily a direct effect like you do on the positive symptoms. Mental planning and thought processes are usually improved for clients, so that's going to help them out also with working and things like that. Antipsychotic medications are seldom fatal in overdose. So generally speaking, people can't overdose on these medicines. Takes a few weeks to see an effect. Improvement will continue for 2+ months. So really encourage them at the beginning to stay on it, keep taking it, because it will take a while to get better. Another thing that interferes with compliance is a lot of these meds are stored in lipids or fats. So they may stop taking them and the body will continue to release them a little bit. So sometimes it's hard for them to see the relationship between the medicine and the improvement, because remember, they start taking the medicine, it takes them months to feel better, so they don't really get the relationship there. Then they stop taking it, but their body still has it in storage, so they don't necessarily get worse immediately when they stop taking it either. So you really have to educate them to help with their adherence so they understand what those relationships are, that they may not see immediate improvement or immediate decline, but that their medicine is still working. We can skip that slide after that. You guys can just skip it because we talk about it kind of in more specific, so you don't need to memorize that. Side effects. First one is anticholinergic. That's a predominant one with a lot of our mental health meds. And kind of the best way to think about that is kind of a drying, like a dry desert. So they're going to have dry mouth. Their bowels are going to slow. They may have trouble with constipation. They may have trouble with bladder problems. So like if they already have some urinary hesitancy or things like that, it's going to exacerbate that problem. So you want to teach them to void regularly. You may have to help them, like they may have to have warm running water to help them start their street and things like that, because it's going to make those things close. They can use sugar-free candies to help with their mouth dryness. Increase fiber in their diet, take stool softeners. They're going to have difficulty sweating too. So if they get out in a high heat situation, their body may not be able to lose heat as quickly as it would have before their medication. So they have to be careful with that. They may have blurry vision. This usually resolves on its own, but they may, if they need eye drops in the meantime, that can kind of help them get through that initial period. They do need to report it though if they're having eye pain or other issues like that. They may need to change medicines. We talked a little bit about sun protection already, hats, sunscreen, sunglasses, report any eye pain, void frequently. The next one on here is hypotension. So we got to teach them to make slow position changes. They need to avoid hot showers and baths that are going to exacerbate that hypotension. So they're going to vasodilate if they get hot right, and then it's going to make it worse when they stand up out of there, especially if it's a bath. Need to use caution in those situations. Some of these meds can cause arrhythmias, so they may need EKGs occasionally for that, be monitoring those. We're going to talk a little bit more about extrapyramidal effects on the next slide, because those are kind of specific to these medicines, or psych medicines in general. Endocrine issues, so beyond just the glucose issues, it can also cause elevation of prolactin levels, which can affect their libido, and can also cause some physical feminine characteristics in men. So that's another thing that can contribute to difficulties with compliance. Metabolic syndrome, we kind of already talked about, so a lot of these meds are going to contribute to problems regulating their glucose and weight gain. They may have sexual side effects. Once again, that throughout mental health nursing, sexual side effects of these meds are things that decrease compliance. So be sure that you know they're reporting those so you can try them on something else, because that is oftentimes something that will make people stop taking a med. GI issues, weight gain, insulin resistance. They also get carbohydrate cravings, which contributes to those the already present metabolic issues. There are a few kind of miscellaneous. They may have jaundice. That's a rare one, but it can occur, so clients need to know to report. They have yellowing skin or sclera. What's sclera? White of their eyes, yeah, because that's oftentimes the first place it'll show up. It'll be more apparent there at least. We talked about hypothermia and sun sensitivity. They may also have wheezing or memory loss. Sedation can be a problem with these meds, and they already are struggling with the negative symptoms of the schizophrenia. So one of the things you encourage your clients to do is set an alarm and kind of set a wake-up time. So if they're in a position where they don't have any energy, they're not working because of their symptoms, they may really need to kind of put themselves on a schedule to get up, to force themselves to get up and moving in the morning and fight through the fog of their medicine. This next one, oh, sorry, go ahead. They can be used for other things. This is kind of the class that's most closely associated with schizophrenia. But yeah, sometimes we can even, like when we talk about sometimes they're used as supplementals in other kinds of treatment too in mental health nursing. Oops. Extrapyramidal symptoms. So these side effects specifically have to do with extrapyramidal tracts. And they're characterized by involuntary movements, changes in client's muscle tone, and abnormal postures. These can all, this set of things can kind of be a major reason people don't comply with their medicine too. Changes in muscle tone, abnormal posture.
I didn't hear you, Hang on.
The higher the doses, high dose traditional meds are more likely to cause these. Lower doses, atypical, newer meds are less likely to cause these symptoms. Akathisia is just restlessness, like a nervous, jittery feeling, restless movement in their legs. This is the most common one. They're going to have a subjective feeling of restlessness, kind of is going to lead to just that, need to be in motion. The opposite of that is the akinesia, which may be the absence of movement, although it's more commonly just slowed movement. Dystonias are an abnormal freezing kind of muscle spasm. They may develop Parkinsonism, which is basically mimicking of a Parkinson's disorder. So the cardinal symptoms of Parkinson's, which are tremors, bradycardia or slowed movement, and rigidity movement. So they may develop kind of those symptoms and appear to have Parkinson's, but it's actually from their medicine. Tardive dyskinesis, which are the next thing on there, is kind of a separate group too, and they're like tardy pupils, they come later. So they typically won't arrive until someone's been on the medicine for 6 months or more before you see these. They're thought to be linked to the medicine resetting the dopamine receptors over time. These are difficult to treat. They are sometimes reversible when you see them if the medication is withdrawn immediately. If it's not taken care of and noted immediately, they're irreversible. So even when they stop the medicine, they don't stop having these symptoms if we don't catch them pretty quickly. Major symptoms that we see with this are tongue writhing and tongue protrusion. Teeth grinding and lip smacking. Typically, the client can suppress those if they actively try to, but obviously that's not a battle that they want to be constantly fighting if they're trying to do anything else. So they're not, so they're somewhat involuntary, but they can be suppressed if they focus on it, but we still want to get them off those meds so that that's not permanent for them. And the last one, oh, two more. The other one's on a separate slide though, is Pisa syndrome. So if you think of the tower, happens more in older adults and basically they lean. So they will lean to one direction or the other. Sometimes that can be treated with Parkinson's meds. Like sometimes if we give those people high dose of Parkinson's meds, it'll improve that situation. And then that last one, neuroleptic malignant syndrome, is a potentially lethal side effect. So we're going to look at it on the next slide by itself. So, NMS typically occurs with high dose antipsychotics, but not always. It is not actually related to a toxic level of the drug, it's just a reaction to the drug. Typically occurs within the first week of treatment. So if we're starting somebody on one of these meds new, we really want to be watching for it. Cardinal symptoms are listed on your slide. They are high fever and rigidity. So temperature especially is what we're monitoring for this. Clients can also experience tremors, impaired ventilation, muteness, altered consciousness. We said high temp is the chief sign. And in these clients, we should not reattempt antipsychotic therapy for at least 2 weeks after their symptoms have resolved. So they're going to need a break before we try them on anything else. A few other notes about these antipsychotic meds is overall. Talked about toxicity. Overdoses are typically not fatal on these meds, so makes them, a good thing to treat people with who might have tendencies towards suicide. Pregnancy, we don't really have great data on antipsychotics, so we don't really necessarily know that it causes severe risk, but we don't have great data that tells us it doesn't either. So a lot of times people avoid those during the crucial first months of pregnancy when we're first forming systems and things like that. Older adults, you may need to reduce dosing. Remember, we talked about when we talked in the fall about the fact that livers slow down, kidneys slow down, so they may have more trouble metabolizing these meds than younger clients. We also remember there are some things that may cause them increased issues with black box warnings, so we're watching for those. There are a lot of med interactions, so a nurse would have to pay special attention to the medications, the other medications the clients are on. tried to kind of hit nursing implications and teaching as we went through. We talked about not withdrawing abruptly, having them let you know if they have a side effect. That next slide is on improving adherence. It's pretty much when you can read. We want to intervene for side effects so that they don't stop taking their meds. If it's something that we can make better some other way. Be sure, like in inpatient situations and outpatient situations, that they're actually swallowing their meds and not keeping their meds. Do discharge teaching. If compliance issues are a major problem and a client is endangering themselves or others, you can consider injectable versions too. Or maybe even if they have transportation difficulties or financial difficulties and it's better just give them a more longer term injectable, you can do that. It's an option. And that last slide, we're going to go back, so don't think you're done, but that last slide, we talked a little bit about early identification and professional evaluation. So a lot of the signs you would see in someone kind of mimic a build-up to the signs that we talked about in full-fledged schizophrenia. So things like deteriorating hygiene in someone who is an adolescent or young adult, withdrawal from activities that they used to enjoy or social withdrawal, academic or athletic decline, changes in personality, if they're making irrational statements, although I have teenagers and I feel like, it'd be hard to sort out from normal teenage behavior. I'm sorry if that's something you guys, I know you're closer to teenagers. I am, but sometimes. Bizarre behaviors, reclusiveness, they are struggling with problem solving, just those kinds of things that are kind of milder versions of what we see in schizophrenia. It's always a good idea to have those people checked out because prognosis is better if we can catch them sooner and treat those things sooner. And that last one, okay, so we're going to go back to nursing process now that we've kind of covered those, but I want to make sure that all that one. Okay. So we can go past that because you know what the pieces of the nursing process are. So key principles. One of the things that your book says that I really like, and I think Mrs. Martinez kind of alluded to this in her last lecture too, is especially when we're talking about mental health nursing, it's more than just providing therapy. So we do med surg to some extent. We're giving meds, like the things we're doing are therapeutic, the tasks. But when we talk about mental health nursing, all of our interactions are therapeutic. Like we are being therapeutic, not just doing therapeutic things. And actually, these clients a lot of times are going to get more out of those little short interactions that you have with them than they are going to have out of like a big group therapy session. So one of the most important things here is building that nurse-client trusting relationship and with these clients. So consistency in staff is key, consistency in rules is key, consistency in your attitude towards the client is going to be key in these situations. The first one on here is be calm. Anxiety is contagious, so this is true of kids too, but the more anxious you get about what's going on, the more anxious they're going to get. And so the more you can, even if you're not calm on the inside, the more you can remain calm on the outside, the less the situation is going to escalate. Consistency, we're building that relationship, we're consistent, the more they know what to expect, the better. What else? Be honest. We're working on building trust, so we want to be sure that we're honest. If we say these are the consequences of a certain behavior, we have to follow through with those. Because once we give consequences, if those things don't actually happen, then then it's not going to work the next time that we're trying to de-escalate a situation. We talked about this a little bit, but focus on the behavior, accept the client, but not necessarily the behavior. So always keep in mind that person that's under there and fighting, basically. So you help them in that fight. You help them fight those behaviors, but you're never fighting your client. You're supporting your client and working against the behaviors instead. Consistency is key. I have it on here twice, it's so key apparently. Balance limit setting with supporting self-esteem. So this can be kind of a fragile thing to do. You have to find those little opportunities to encourage them, those small victories. So you're gonna have to set limits on behavior, but you also wanna be looking for the good stuff, right? The things that you can say to them, hey, your hair looks really nice today, or I like that shirt that you put on this morning. The things where you can encourage the behaviors that you wanna see and help build their self-esteem at the same time. Some do's. We want to orient them to the person, place, and time. We want to reinforce the reality. However, we're not going to argue with the client regarding their reality versus our reality. And we don't want to be continuously pointing out the correct reality versus their reality because that's not helping them with their self-esteem at all. And we're constantly just telling them, no, you're wrong. This is what's going on. So we want to acknowledge their reality. We want to acknowledge the feelings that they're getting from their reality. And so we can present kind of, okay, well, I know that you're hearing this and that's got to be really frightening for you. I don't hear it, but I understand that it's frightening. We want to be listening. Even within delusions and hallucinations, we can find themes that we can kind of start to figure out what treatment the client might need. So even in disorganized thought, sometimes there are themes. There's a spot in your book, and I don't know the page number down, there's a little box on the bottom of the page that talks about loose association, and it's basically a person dropping a whole bunch of different words. But when you really stop and look at it, you see some certain themes coming out. So getting good at spotting those themes, even in things that don't objectively on the surface make sense, can help you become a better nurse for these clients, because it will tell you what the things they're really dealing with down deep. Did you find it? Where is it? That's on 254. If you want to read through that and kind of exercise that at some point for yourself. We need to help them focus on real people and real events. So there's a good little, see if I can switch back over without here. Oh, I logged out. Might not be very easy to do this. Yeah, along the back one, that's not much sure. I thought this video was kind of interesting, not that we're going to watch the whole thing, because it's not necessarily towards the
I love the new My WW program because it's tailored to you. Take the personal assessment.
Possible, so that we can start to heal the divisions of the campaign and
secretaries, businessmen and women, military and federal
almost a
workers,
century and a half ago, Senator
moms
Stephen
and dads,
Douglas told Abraham
friends and
Lincoln, who
neighbors.
just succeeded him for the presidency,
Thousands of lives were suddenly
partisan
ended by
zeal
evil,
must yield to patriotism.
despicable acts of terror.
I'm with you, Mr. President, and God bless you.
Pictures of airplanes flying into
Well, in
buildings,
that same spirit,
fires
I
burning,
say to
huge
President-elect Bush,
structures collapsing.
What I like about that video is, I mean, those are totally sane stimuli that you're getting in, right? But it's really hard to focus on either one of them, right? It's hard to pick one, it's hard to understand what's being said. So you have to keep in mind, that's going to be a constant battle for these clients to figure out which of these voices is the real one, which of these voices do I need to be listening to. So that's part of your role as nurses to kind of reorient them basically to the present, reorient them to focus on that voice that is the real voice, or the real situation. So that's when it talks about focusing on real people and real events, it's kind of that constant. That's kind of why I wanted you to look at that and see what it's like to hear those two things coming in at once. So they need your help sometimes to sort out which one of these is the real voice and which one is not the real voice, if you think about those videos and things like that. So reorienting them to real life events. Oh, I need to make that big again, don't I? Start with one on reinforce positive behaviors. We kind of touched on that one. Start with one-on-one interactions. One-on-one interactions with you as the nurse are less threatening, more predictable, more likely to be therapeutic than trying to immediately push them into group situations and things like that that are going to be overwhelming for them. You want to allow and encourage verbalization of feelings. This goes back to that whole, you don't want to be constantly arguing with them about the fact that they're wrong, about their hallucinations or their delusions, because it really discourages them from communicating with you. And then it's hard for you to find out what's really going on behind those things. So it's okay to say, you know, I don't see that, but really keep along the train of thought. Don't get in this position of trying to argue down delusions and hallucinations, basically. Explain to them what your reality is, but encourage them to talk about what they're seeing and hearing. Beyond things, you may also find triggers. So you may find that when they watch a certain program or things like that, and when you're planning them, the view or the environment, you want to keep those things in mind. Certain things, certain movies, certain types of music are going to be more likely to trigger people with schizophrenia than other more calming influences. So like even like in the day room, if there's a TV on or something like that, you want to be careful about what's on that TV or what sort of music is playing in the background. Diligently try to understand them. We kind of talked about that, so I think you guys have that, you know, listening to things that even seem garbled and trying to find the messages under it. Some don'ts. Don't touch your clients without warning your schizophrenic clients. Obviously, if they're in that constant state of feeling threatened and anxious, a touch is going to cause them sometimes to even be hostile. They're going to feel threatened by it. So you always want to make sure that they know before you touch them. Don't reinforce their hallucinations, but like I said, do investigate them. If it looks like they're listening to something that you can't hear, looking at something you can't see, ask questions. Kind of find out what they're seeing, what they're feeling. Find out what themes you can get out of that. Don't argue about delusions. Avoid whispering or laughing if the client cannot hear the entire conversation. So you may be up at the nurse's desk telling a story about your kid that's totally funny and has nothing to do with your clients, but remember, schizophrenic clients have that idea of reference. So if you're up there laughing and talking, they're going to feel like that's about them. They're going to feel threatened by it. What's the next one? Do not embarrass the client. Obviously, they're already struggling. They're typically aware that they've got a declining mental health. They're struggling socially, so we want to be careful not to embarrass the client. We want to be sure we talk to them privately if we need to talk to them. We're not going to make fun of behaviors or things like that. I think that comes pretty naturally. You may want to also avoid competitive activities. They can be threatening and have negative effects on their already weakened self-esteem. So it's better to encourage kind of calming activities like puzzles, coloring, art, drawing, maybe taking a walk around the unit, things like that, instead of competitive activities. Then we've got key principles for the review. You want to modify the environment to decrease stimulation. So that just makes sense with them. They're dealing with a lot of incoming stimuli. We don't necessarily want to add to that and add lots of sounds and sights and things that they also have to process. So we want to keep their environment calm. We want to have consistent staff. Adds predictability to their environment, allows them to build those trusting relationships with people, allows for greater continuity of care. We want to arrange the environment to reduce withdrawn behavior. So we want to maybe group our chairs so that they kind of are in groups rather than encouraging someone like a single chair off by itself in a corner where that will encourage their withdrawn behavior. We talk about this with some other disorders. Sometimes you also need to close off sleeping areas to encourage people to remain active and out during the day rather than just kind of getting into that desire they're going to feel to withdraw from society. You also need to be sure that environments are safe. I don't know that that's on this slide, but we'll talk about this. And if you've already done St. Anthony's orientation, like even their chairs are specially designed so they can't be picked up and used as weapons. You're not going to have anything on the unit that can be thrown or used to harm somebody. One of these those, you're not going to have name tags that pull out because that could be used as a ligature to choke somebody. So just kind of thinking about your environment and making it as safe as possible too, because they're going to have escalation sometimes, and you want to be as prepared for that as you can be. Monitor TV watching, so we're going to choose our programs and our music carefully. Several of the, you notice in some of those videos, it's a news program. So, the news can be frightening, and so, that can be triggering too to them. You want to protect their self-esteem, so we've kind of already covered that. Separate the client as a person from the signs and symptoms of their illness. Look for opportunities for small victories. Offer positive reinforcement when you can. The next ones are fairly specific. So the next one, how much time? We've got 11 minutes. We'll see where we get. So clients who are disruptive is the next slide. You want to set limits on disruptive behaviors. Decrease stimuli. Observe frequently for escalation. If you can catch escalation earlier, you have a better chance of intervening before they kind of reach a full escalation. So be watching for those signs and symptoms. You want to minimize things in the environment that can be used as weapons. State consequences carefully and follow through. Use restraint judiciously. Try and document other options first. Calm your environment. Take a walk. Talk. Use distraction. All those other things before you use restraints. If restraints become necessary, then you want to ensure that hydration, elimination, nutrition, and circulation are taken care of for those clients while they're in restraints. This is a new one if you want to take pictures of it that I added later from another section of the book. This one is specific to clients who are exhibiting violent behaviors. So you want to maintain a safe distance. Basically, you want to be out of the strike zone when someone is escalating and violent. You want to seek approval before touching them. Like we talked about, that can feel like an additional threat. You want to pay attention to when the topic needs to be changed. So if you're discussing something and you can kind of see someone escalating, you may need to change the topic because that may be a topic that is triggering from them. If you see someone escalating, you may want to encourage them to take a break, reduce their stimuli, get in kind of a more quiet area, give them a chance to kind of calm back down. Number 5 is that you want to avoid being alone with the client in an enclosed place. That's pretty obvious. If they're escalating, you don't want to get in a room alone with them, but it might be appropriate to just kind of walk around the unit with them and kind of give them a little space to calm, someone to talk to, but you don't want to put yourself in a dangerous situation. If it's possible, honor the request for alone time. So depending on the situation, whether self-harm is an issue, what else might be going on, if they just need a few minutes and that's something that is reasonable and feels safe, then let them have a few minutes. I know for me, I have a child who has anger issues and sometimes he just needs to walk away, and that can be really frustrating to me, but sometimes that's really all he needs is a few minutes to kind of recenter and then he can come back into the situation. So clients may experience that as well. So if it's safe and it's something that you feel like you can honor, try to do that for them and let them regain that sense of control over their environment. Call out for assistance if you need it. So don't wait until something is fully escalated to get help. Clients who are withdrawn, they specifically need non-threatening activities. So the art, the walking, the painting, things that are calming, non-stimulating, non-competitive to kind of move them back into that social network. So taking that slowly. Use the environment to encourage interaction. We kind of talked about that one in terms of planning your environment. Encourage them to be out in like a day area with other people so they're getting a little bit of socialization there. Assist them in assisted involvement in decision making. So you're not going to push them to make decisions, but when they're in a good spot and they can, then get them to make the decisions they can, provide positive reinforcement for that, but don't push it too far. Don't push them beyond their capabilities to where they start to shut down again. Reinforce the grooming and hygiene behaviors. Once again, positive reinforcement on those. I see that you blah, blah, blah. I like that you blah, 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 to encourage those behaviors. Providing psychosocial rehabilitation. So these clients may need active skills taught to them, some of the things that come naturally to you, like social skills, community living skills, health and hygiene. Those things may not come because of their disorder naturally to them anymore, so they need to be maybe cognitively taught the same stuff that would come naturally to you. Next one, clients who are suspicious. So if your client's suspicious, you want to be a matter of fact with them, communicate simply, clearly, keep all your messages congruent, and offer simple rationales for what you're asking them to do. Keep things very simple and be very honest with them so you don't build into that suspicion. To again, avoid laughter and whispering unless the entire conversation can be heard by the client. Do not touch your client without warning. Avoid close physical contact when you can. Provide consistency, so consistent schedules, consistent staff, doing things consistently. Maintain eye contact. Encourage them to participate in activities, but don't force them to participate in activities because that can feed into that suspicion. Clients with impaired communication, you want to be patient with them. Remember, it's not just their communication that's impaired, it's their thought process behind the communication. So you can't really pressure them to make sense because they really can't make it make sense for you. So pressuring them is just going to further frustrate them. What else? Do not pressure them to make sense. Do not push them to group activities that are beyond their capabilities. Once again, small baby steps. So encourage them, small victories, positive reinforcement, but don't push them into situations they're not ready for. Provide opportunities for purposeful psychomotor activities so that they can kind of do things that don't necessarily involve communication specifically, but they can be active in other ways. Some of the same concepts we talked about, a lot of these things are going to overlap. The next one is hallucinations. So clients with hallucinations, provide those same kind of mild calming distractions we talked about. Discourage them from sharing their altered perceptions with other clients if you can, because that's going to cause kind of a building psychosis among groups of people. Because if they may talk to someone and then if they validate those inaccurate perceptions, you may kind of get a growing sense of suspicion and upset that builds on each other. So talk them through with you, but try to avoid having them share those things with other people. Monitor their entertainment choices, because some things are going to contribute more than others. Make them calming. Be alert for command hallucinations. So remember that auditory hallucinations especially can contribute to harm of self or others. So we really want to watch those hallucinations. Be available, provide real life interactions for them. So put them back into reality, provide them with real conversations and real activities to focus on. One more new one I was going to get to. Clients who are disorganized. Similar stuff, calm environment. Staff stays calm. You may need to move them to a less stimulating environment. Provide those safe, simple activities that can distract them. And this one is new. clients with delusions. For the most part, it's a new slide, but it's concepts that we've already talked about. Encourage them to share the meaning of their delusions. Ask them to tell me more about what that delusion is and what it means to you. And for themes, concepts, possible triggers, similar theme for delusions and hallucinations. Have them explain to you what they see, what they hear, what they feel. Focus on validating the emotional experience created by those themes, not on arguing the actual content of their delusions. Another thing that's important in that last line about harm of self or others, monitor clients with delusions because they can lead to self-harm or harm of others. But keep in mind that harm can be an active or a passive term. In some of those videos we saw like that they were afraid to take their medicines or afraid to eat. So not only can it be a physically like I'm going to hurt myself, it can also be that their thoughts and their delusions keep them from doing the things they need to do to take good care of themselves. They're not eating healthy, they're not eating at all, they're not taking their medicine. So be alert for those kinds of things as well. I think this might be our last one. Yep. These are not things you need in there for the test, but I just wanted you to kind of have heard of them. So, we'll run through this real quick. You don't need to necessarily study it for me. Delusional disorder has the delusions of schizophrenia, but not the other symptoms. They may also have hallucinations, but these are people who are functional. So they have some hallucinations, some delusions, but they remain they're more functional. They haven't reached the point of schizophrenia. Brief psychotic episode is any psychotic disturbance that is less than a month. So it takes a while for us to officially give someone the diagnosis of schizophrenia. If you look back at the DSM-5, I think it's 6 months. So basically we've got some other categories for people who are showing those symptoms, but we don't necessarily want to label people as schizophrenic the moment that they have psychotic symptoms, because sometimes it's due to other things like a medication or some sort of substance abuse or things like that. So the brief psychotic is going to be that first kind of month section in there that they're showing psychotic behaviors. Schizophreniform is the section after that, from the end of month 1 to the beginning of month 6, basically. So that's a period of time. They're still showing these signs and symptoms, but they haven't had them 6 months. They're not officially diagnosed with schizophrenia, but they're still showing some psychotic symptoms. Schizoaffective, and I did see some people commenting on those YouTube videos who have been diagnosed with schizoaffective, and basically it's a combination of schizophrenia with an affective disorder, which we haven't talked about, but affective disorders have to do with the affect or the feelings. So that's things like depression and mania and things like that. So they're schizophrenic, but they also meet the criteria of being depressed or manic or bipolar or something like that. We've got 1 minute. Does anybody have questions? That was a lot. Do we have questions anyplace else?